I know this is the end of the day. I hope that you enjoyed the bunch of cases presented all through the 2 days, especially the last one, which is joined by the JAC case reports. They presented fantastic, highly educative, up-to-date cases. And now I have to finalize our task for CardioGo 2021, and I'd like you to thank the every pharmaceutical company who gave us the sponsorship for this CardioGo to succeed. And one of those partners actually are the sponsors for this session, which are the Astra company. I'd like to thank them because of their continuous support for all the CME's activities for IAVA and for CardioGo. My presentation actually was about one of the important everyday practice about those patients with hypertension and dyslipidemia patient beyond the control with optimum protection. As we all know that the hypertension and dyslipidemia, both of them are actually silent problems. And because of their silence, we are facing a challenge in managing them and to cut down the very high risk problems they put at the patient for it, which is like the acute coronary or acute cerebrovascular events. As we all know that the cardiovascular disease prevention is our task, is one of the more major tasks in the health promotion, starting from the primordial prevention for the even fetal and infant health, smoking, physical activity, body weight control, environmental pollution and diet, up to the primary prevention from controlling the risk factors like dyslipidemia, hypertension, diabetes, metabolic syndrome, and finally the secondary and tertiary prevention for those who are actually subjected to cardiovascular disease, coronary artery disease, or peripheral heart disease, and the consequence of the heart failure and the cerebrovascular disease. Unfortunately, what we always see is the ice of the berg, the top of the ice of the berg for the atherothrombotic problems, the acute plaque rupture and the acute event like unstable angina, nestomy, or acute myocardial infarction. But actually what is being more important, I think, is to predict and to uncover the subclinical problem like the presence of multiple coronary plaques, persistent hyperactive platelets, and vascular inflammations, because all those which are down, we cannot see them, are the responsible for the ice step of the iceberg, which is the acute plaque rupture and acute cardiovascular event. A lot of playmakers, but I think, and as we all know, the dyslipidemia is the major playmaker in the formation of the atherothrombotic complications and the vulnerability of the plaque acting with the other bad guys like hypertension, smoking, diabetes, high-fat diet, lack of physical activity, and family history of early coronary artery disease. Actually, we have the synergistic actions of hypertension and dyslipidemia. Both those bad guys acting on the same pathway with a synergism for loss of the endothelial function, and by dealing with this also in a synergistic way with the statins and with antihypertensive medications, we can do an increase in the endothelial function, which might be lost during the dyslipidemia and hypertension course. Again, like our theme, which is just cases, we will dive shortly through a case scenarios. Mr. M is a 45-year-old male smoker presenting to outpatient clinic with palpitation, flushing, and headache. On examination, repeated clinic blood pressure 160/100. Heart rate here also is 95 beats per minute. It's not quite good. Chest was clear, normal heart sounds. CBC, chemistry are other chemistry are remarkable. A1C 6.2, lipid profile triglyceride 220, total cholesterol 240, and the LDL actually is elevated to LDL 140. So this patient, as you saw that he is hypertensive and dyslipidemic patient. If we go to the classification of the risk of this patient, what is the classification risk for the patient according to the ECC 2018? As being an hypertensive patient, he is low risk, moderate to high or high risk patient. If we have a look here to this very important chart, because hypertension is not only figure. Hypertension is figure plus another risks. And because of this, they classifying the hypertensive, those figures to hypertension disease staging, stage 1, stage 2, stage 3, and we can here appreciate that for those patients, even with blood pressure 130 to 140 or 85 to 90 diastolic blood pressure, which is considered for most of us as normal, if they had another established cardiovascular disease or CKD more than 4 or diabetes with organ damage, they will be considered as very high risk patients. So it is not only figure. Sometimes with mild elevation of the blood pressure, but a cluster of risk factors, we have another stage of the disease, and we may put the patient in a very high risk situation. So that's very important to combine between figures and risk factors for proper management and proper strategic management for those patients. So this patient, as you saw, because of the blood pressure on 160 over 100 and the dyslipidemia, which is another risk factor, these patients, and he is also smoker and male, so more than 3 factors of risk factors. So this patient is considered as a high risk patient. And this is will of course reflect our, we're also the target of, will be reflected on the target of the blood pressure patient according to the ECC guidelines. Is it will be from below 120 over 80, 120 to 130 over 80, or from 130 or 140 over 80. And I think here, because of the risk profile, as we did from the risk categorization of these patients should be kept to the target of 120 to 130 over 80. This is a very important figure to remember in high-risk patient. The question here is to achieve this target by lifestyle only or lifestyle and immediate drug treatment. Here is another very explanatory graph by the European Society of Cardiology, which describing the way we will start lifestyle only if the blood pressure is only high normal. For those patients with grade 1 hypertension, we have to start, of course, with lifestyle advice. Then of those patients at high risk or very high risk, we have immediately to start the drug therapy. But if they are moderate risk, we will start lifestyle modification for 3 to 6 months, and we recheck the blood pressure. If it is still high, we will start the immediate blood pressure reducing drugs. Here our patient is, of course, is grade 2 hypertension, so immediate drug treatment here will be the strategy. Another important point which I'd like to declare here is the aim of the blood pressure control. We have to reach it within 3 months. Sometimes during our practice, our patients are in a hurry to reach the target blood pressure maybe within days or even weeks, but here we have to keep in mind and we have to explain to the patient, and we can reach our target for this blood pressure within 3 months. Another question, start monotherapy or start combination therapy? If you allow me, I'd like to declare here one of the statements that is the coming era will be the era of combination therapy. For hypertension, it is started already, and I think also it will be for the soon for the dyslipidemic patients. And actually, I cannot say that in the presence of Professor Khalifa, but also I think for diabetic patients also the place is came to the stage for the combination therapy for the diabetic patients. So now we are in the era of the combination therapy, and here is the guidelines also declaring so that the combination treatment is recommended for most hypertensive patients at an initial therapy. Preferred combination should compromise RAS blocker. RAS blocker should be one of the combination with TCB or diuretic. And another class 1 recommendation here, it is recommended that beta blockers are combined with any of other drug classes when are specific clinical situations. So beta blockers is a class 1 level of evidence A recommendation when we have angina, post-myocardial infarction, heart failure, or even heart rate control. Because sometimes we neglect the heart rate, the tachycardia as one of the risk of cardiovascular disease. We are aiming only for the blood pressure, but we have also to aim the heart rate. And here is we have a recommendation, if class 1 recommendation to combine our antihypertensive with beta blocker if we are not reaching the target for the resting heart rate for the high risk patient. So of course it will be the combination therapy, and here we will choose the ARB as the a mandatory one of the combination therapy, and the beta blocker, because as you see the resting heart rate of this patient is 95, which is not quite good for such a high risk patient, because the aim of heart rate to this patient may be from 60, resting heart rate from 60 to 70, so we are still far away from the target of resting heart rate for this patient. And if we have some of the postulated mechanisms of the hypertension, we can also thinking about the drugs which we can use to control these patients, the postulated mechanisms, either sympathetic nervous system overacting or renin-angiotensin system disturbance or total body or elevation of total body sodium. And I think here in these patients, our aim as a mechanism behind the control of blood pressure is to do sympathetic nervous system modulation and the renin-angiotensin system also modulation. To achieve this, I think the beta blocker will be one of the tools and one of the weapons which we can use, maybe like metoprolol succinate with a prolonged release like the silocanzoc. Why we choose this molecule, I will tell you. Also achieving the control and the sustained control over 24 hours is a very important issue when we are choosing the beta blocker, because the beta blocker all through the history is famous of being not keeping up the sustained blood pressure control, and we facing with the beta blockers, of course, the various, the old versions, the blood pressure variability when you are using the beta blocker. So when we are choosing the beta blocker, we have to have a 24-hour sustained control. Of course, here the data give us very important evidence that metoprolol succinate prolonged release 100 milligram has proven efficacy in controlling hypertension and the heart rate. So we are now achieving a control of two risks, the blood pressure and also the heart rate. Sometimes with 100 milligram, we can reach up to 63 beats per minute. What about the sustained controlled blood pressure over the 24 hour, which is already present in the metoprolol succinate? The tablet comprise a multiple unit system which is called the pellets containing metoprolol succinate, and these pellets acts as a separate drug delivery which can do the delivery to the metoprolol continuously over the 24 hours, which I think will keep up the sustained blood pressure control all over the 24 hour. Also here, all through the history of treating hypertension, we know that combining with hydrochlorothiazide or the diuretic with any form of antihypertensive, it will give us a good control of the blood pressure. But what about the mortality when combining with the hydrochlorothiazide? Is there any effect on mortality? This important paper gave us some of the data about that the evidence for the long-term trial is mixed over beta blockers are generally less effective than diuretics, yes, and are usually no better than placebo in reducing cardiovascular events. The exception was one large trial in which the treatment with metoprolol, here we came with the evidence with the metoprolol as a beta blocker resulted in a lower all-cause mortality than treatment with thiazide diuretic. So it is of value to combine any of the antihypertensive treatment if needed, if indicated, with the beta blocker, because now we have evidence for blood pressure control and also for mortality over the thiazide diuretic. Metoprolol is the only beta blocker with primary prevention a hypertension trial among all beta blockers, and we have what's called the MAFI trial, the metoprolol atherosclerotic prevention in hypertensive patient. And this study gives us an important evidence that cardiovascular mortality is reduced with metoprolol by 58%, which is a very considerable percentage of reduction of mortality with one of the antihypertensive drugs like metoprolol or like beta blocker. Also, when you are choosing the medication for the hypertension, if it is covering a lot of indication, of course it will be one of choice. Like the beta blocker here, the metoprolol succinate. It is used in hypertension, used in angina, used in post-MI, congestive heart failure, and we have evidence for use of metoprolol succinate. I think it's one of the earliest. Arrhythmias, heart disorders with palpitation, even with migraine. So if you have a beta blocker which can control the blood pressure and also control all of the combined clinical situation, I think it will be of choice like the metoprolol succinate. So here, come back to our patient. The optimum dose to start with in this patient is Seloken-Zoc 100 milligram, because I like to remind you that the heart rate of this patient was 95 and we'd like to reach it up to 60. But we still have another bad guy, another playmaker for the vulnerability and for the atherosclerosis, which is dyslipidemia. I'd like to remind you here that we have to know baseline of the LDL of this patient, which is 140, and also to know the intensity of the statin or the combination which we will use, the percentage of reduction to reach the target of this high-risk patient, which I think we have to reach up to 70 milligram per deciliter for the LDL from 100 milligram, 140 milligram LDL. So I think we need a drug that will reduce this LDL up to 50%, and I think even the FDA proven that some of the drugs monotherapy can do like combination in reduction the LDL, for example like the rosuvastatin 20 milligram can act like a combination with of simvastatin ezetimibe in reducing the LDL by 55%. So I think by choosing a molecule like rosuvastatin 20 milligram with a starting LDL of 140, we can reach up to 70 easily by this concentration of rosuvastatin. I'd like to take you finally to the take-home message for the sake of time. The Seloken showed a control of both blood pressure and heart rate, and this is very important to remember because our target is not only hypertension, but also the heart rate as a risk for cardiovascular disease. The sustained control is also important because leaving the patient uncovered for hours all through the days are elevating the risk of cardiovascular events. Seloken is only beta blocker with extended mortality, as I showed you in the study, benefit in hypertensive patients, and also, which is very important, Seloken is the only beta blocker approved in the 7 indication, as I mentioned. And about the control of the other bad guy, which is dyslipidemia, as I showed you that the rosuvastatin crystal showed superior efficacy in LDL reduction up to, for 20 milligram, up to 55% of reduction. Crestor is approved to slow the progression of atherosclerosis. Also, we have some of imaging studies that showed us that by proper reduction of the LDL, like the rosuvastatin did, we can also have a slowing of the progression of the atherosclerotic plaques. And finally, the long-term treatment is also important. Not only the control of the LDL for a time showed significant reduction in primary major cardiovascular events by 45%, and this takes us that we have to use for those patients with high risk a statin for life. And thank you for your attention.
شكرا دكتور سيد على المحاضرة الجميلة ديت. وأنا كنت عايز أسأل هل ممكن إضافة العيان ده محتاج فول أب بعد كده علشان الهايبرتنشن، يعني هل ممكن suggest لو الهايبرتنشن still not optimally controlled, what type of other antihypertensives you would like to add?
Professor Audi, this is a very important question because sometimes you are not easily get to the blood pressure target. So we have to follow the evidence. And the evidence here, we are obliged to use beta blocker because of the high heart rate with the RAS blockade. But we're still missing one of the combination therapy, which is evidenced as class 1 recommendation level of evidence A, either the CCP or the diuretic to combine. We still have this recommendation to add, class 1 recommendation. So if the blood pressure is not yet controlled, I think we can add the CCP or the hydrochlorothiazide or hydrochlorothiazide like diuretic.
هل أنا أقدر أضيف إيزيتامايد عليه لو ما وصلتش للتارجت؟
Of course, this is a very important question. Thank you, Professor Magdi. I think that the coming era also will be not the high-intensity statin, but the statement of high-intensity lipid-lowering therapy. And as I started my presentation, it will be the era of the combination. If you are not reaching the target by evidence and by guidelines, also we have to combine with ezetimibe. And by the way, it should not be the same pill. Maybe 2 pills, one for ezetimibe and one for the rosuvastatin, for example. Or if you have one pill, it will be better for compliance. And if not, especially in those patients with high risk and very high risk patients, we have as early as we can combine with PCSK9 also to reach the to reach the target. So the concept of high intensity lipid lowering therapy, especially for those patients with high risk and very high risk patients, should be applied for every patient and should be meticulously followed by follow-up of her or his LDL during the course of treatment.
حضرتك ال LDL to which level عايزين نوصل؟
To reach the target for the very high risk patients is 55 for those or down. For those high risk patients should be 70, and for those moderate risk 100, and those low risk should be below 115.
Thank you very much.
Thank you very much.
Any question? Thank you very much
Thank
for
you.
elegant talk.